India firmly and consistently
Hello.
opposes projects in the so-called CPEC, which are in Indian territory, that has been illegally occupied by Pakistan.
हेलो गणेश, तेरा केस पहले ले ले क्या?
हाँ ले लेते सर.
ओके, तो मैं पारस को बोलता हूँ.
Yes, and we can start also. I'm free.
नहीं, let the हेलो पारस. Paras?
Yeah.
Paras, can you hear me? Hello.
Sir, good evening.
Good evening, Mahendra. All set? Answer देने के लिए.
Hello, Paras.
I am ready.
Hello, Paras.
Hi Ganesh.
Hi sir.
Hi Pankaj sir. Good evening sir.
कैसे भाई?
आप
Fine,
किधर
sir.
तो
आप
उधर
कैसे?
थे ना? क्या वो USI वाला
Yeah, I was at Hyderabad over weekend.
खत्म हो गया?
Yeah, it was Saturday, Sunday. So Saturday I attended that youth meeting and Sunday we had a council meeting.
Hello, Paras, can you hear me?
कान बंद कर लिए.
Hello, Paras. Okay, Paras, can you hear me? Hello. Paras. Hello.
Gite sir, good evening.
Good evening.
Good evening, sir.
Good evening, sir. अच्छे दिख रहे हैं. आज हमारा प्रेजेंटर भाग गया है.
नहीं सर, ये काफी कंसिस्टेंटली 3 साल हो रहे, तो थोड़ा थोड़ा बीच में तकलीफ होती है. आप हम सब लोगों का टेस्टिंग कर लेते हैं बीच बीच में, जो भी प्रेजेंट करो.
I think like unusual cases, unusual situation they are creating.
करेक्ट है. पंकज सर, गुड इवनिंग.
Good evening, sir.
पारस.
We just wait for 5 minutes. 9:10 we start.
ओके सर. So it is 23 people only. 5 मिनट वेट करने में कोई हर्ज नहीं.
करना है?
I think we can start now.
Yes, sir.
Okay, Paras, you can start.
For the first case, Dr. Adit Parekh would be answering.
Good evening, sir.
Starting with the case, presenting case history of 36-year-old gentleman, engineer, resident of Ulhasnagar, presented presented with difficulty in urination since 3 years, blood in urine on and off since 1 year. History of present illness. History was given by patient himself and seemed to be reliable. According to him, he was asymptomatic 3 years back when he developed difficulty in urination. Patient has increased frequency, which has progressed from 7 to 8 times to 14 to 16 times at present. Patient also complains of intermittency
Voice?
since last 1.5 years. There is also history of urgency since 6 months without involuntary leakage of urine. There is also history of on and off burning during urination. Patient also complain of pain in lower abdomen during the time of urination since 6 months, which is dilating, radiating towards the penis, increased on straining, and is relieved after passing urine. Patient also complains of on and off blood in urine since 1 year, sudden onset, progressive, complete, not associated with passage of clots, and is associated with pain in suprapubic region as described above. The episodes were relieved by medication. The IPSS score frequency is 4, urgency 3, nocturia 2, poor stream is 1, intermittency 2, straining 4, and sense of incomplete voiding is 3.
Who is answering?
Sir, I'm answering Aditya.
So Aditya, what any other history you want to know?
Sir, I want to know if there were any episodes of urinary tract infection, whether there was any history of lithuria, and about the stream of urination, whether it was improving on straining or it was worsening on straining or remaining the same. Also, in terms of the poor stream, whether the stream was thick and falling close to his feet or it was thin and falling away. Whether he has any past history of stone treatment or stone surgery, any intervention done for the lower urinary tract, or any history of prolonged catheterization.
So there is no history of fever, nausea, and vomiting. No history of any urethral instrumentation or surgery in past. No history of any bleeding disorder, anticoagulant therapy, or blood transfusion. No history of lithuria or trauma. No history of facial puffiness, pedal edema, or breathlessness. No history of jaundice, headache, or backache. The urine stream improved on straining, and it is not thin, but it is going. It is thick with, and it is not falling on the.
Yeah,
Past
Aditya,
Yes, sir.
anything else you want to ask? Just tell us.
No, sir. I think the history is quite complete, sir.
Okay, fine. Paras, go ahead.
Past history and comorbidities. No as such comorbidities or any surgery in past. Personal history. Patient is mixed by diet. No allergy to any food or drugs. Sleep is normal and undisturbed. Bowel habits normal and adequate. No addiction to any form of tobacco and alcohol intake. Family history is nothing on.
Can you go
Yes.
back to the history once? History, the first slide.
Paras, show the first line, the first slide.
Age 36. Okay, sorry.
So blood in urine since 1 year.
1
Next
year.
slide. Next slide now.
Frequency burning pain in lower abdomen, radiating towards penis.
The one thing patient has increased frequency, which progress from 7 to 8 times for 40. But what is the time duration?
And
It
in 3 years.
progresses. So progresses from 7 to 8 times to 40, 16 times in 3 years.
Yes.
Okay. Any history of retention of urine?
No, sir.
Did you ask?
Yeah, yeah.
Yes, sir, it is me.
Retention of urine.
No, sir. No retention.
You should ask actually. When such a history is there and you think about something benign thing, so it should be there. Sometime patient may have a small stone in the urethra that impacted when you apply pressure. It passes. Okay.
Yes, sir.
Yeah. Okay. I think history is okay, sir. Ganesh sir.
Okay.
Yeah.
I was going to ask what is the clinical thought diagnosis.
Okay. Yeah, that is okay. I think history is okay. This is all done. Anything examination by history? What do you think?
Sir, my differentials based on history are urethral stricture. Second would be bladder stone. Third would be bladder mass. And the
Urethral stricture.
urethral stricture, sir, yes.
Urethral. Okay.
Urethral stricture.
Okay. So radiating pain. There was a radiating pain from lower abdomen to the penis.
Yes, sir. Yes, sir.
So why urethral stricture first diagnosis?
So first would be bladder stone. Given his age, the history typically suggestive of strangry. So I would put bladder stone first, bladder mass, and then the third would be urethral stricture. Ureteric stones, but the duration is quite long and there is no history of flank pain. But the fourth would be ureteric stone, lower ureteric stone, which may be causing the strangry.
So again, my question is why bladder mass is the second DD in this age group, 36 year of age group?
Sir, because he's having off and on hematuria and which has progressively increased over a period of time. So that is one thing that would be more suggestive of bladder mass.
Then should be the first one.
Sir, but the presence of the bladder stone has one is young age. The second is the presence of strangry, and the third is hematuria. These three factors are in favor of the possibility of a bladder stone. Age is against the bladder mass. This is not typically the age for developing a bladder mass. And the third would be a urethral stricture because he's a young male with lower interact symptoms that have progressively worsened. And the fourth would be a lower ureteric stone, given that he is having this history of strangry, and even in the presence of stone in the upper tract can cause off and on hematuria.
So, but again, I think in this age group, the bladder tumor should be not the second; it should be the third or fourth one.
Okay.
Yeah. And I think Ulhasnagar is a belt of stone, if I'm not wrong. Patient. Okay, fine. Now, what next you will do?
Sir, next I would like to examine the patient. I'd first do a general examination, followed by palpation of the inspection, followed by palpation of the abdomen, back and spine examination, a digital rectal examination, examination of the genitalia.
Okay, so what positive or negative things you are thinking?
Sir, I want to see if
But in this case,
the bladder is distended, whether I'm able to palpate the bladder or not. I want to check the meatus of the patient. I want to see if there is any, and I want to palpate the urethra to see if there is any induration. And I would also like to do a digital rectal examination as the cursory investigation to see if I find anything
Why should
on.
bladder be palpable in 36-year-old?
Sorry, sir.
Why should bladder be palpable?
Sir, he is giving a history of progressively worsening urinary tract symptoms, and his frequency has gone up. So he may be keeping a large amount of residual urine, which is why he's having this frequency which has worsened. The other possibility is that he's having this often on hematuria, which may have led to to clot and some amount of residual urine as a result of clot.
Residual urine resultant of clot.
Because of clot, he may have clot
That is a little bit
retention.
far-fetched.
Yes.
Clot will give directly retention of urine if that is so.
Yes.
I don't know, residual urine is because of usually prostate enlargement or probably directly tumor which is there in the tricone which may obstruct the bladder.
Okay. Sir.
So in general examination was done in a well-lit room and with proper exposure and content. The general examination is grossly normal. The abdominal examination exposure was done to nipple to knee. Inspection abdomen is flat, umbilicus is central and inverted, no visible lump of peristalsis, pulsation and gauge vein or stomach, all quadrant moving equally with respiration. Palpation, no positive finding. Genitalia, uncircumcised penis with the retractile prepuce, external urethral meatus is normal, bilateral testes and cord are normal on palpation. On digital rectal examination, no fissure, fistula or hemorrhoid, no tenderness, prostate fossa is flat, no mass palpable in the rectum, fecal staining present, blood staining is absent.
you should also palpate the urethra in the perineum and in the penis, just to see any abnormality and something hard fibrous tissue around the course of urethra. If you are suspecting urethral stricture.
Yes, sir.
All the systemic system are within normal.
Okay.
So the examination is grossly normal. And, I would like to proceed with to investigations.
No, what is in your mind now? What now you have history, you have examined the patient.
Yes, sir.
Now you should narrow down your DD from the
Yes,
4. It should be something less than your initial
Yes,
DD.
sir. Yes, sir.
Yeah.
Sir, in my first differential would remain bladder stone because there is nothing to suggest that it may not be a bladder stone. The second would be a bladder mass, but because the presence of a bladder mass, if it is a small bladder mass and it may not necessarily be palpable, there may be no abnormal DRE findings, and the stricture goes a little below, sir, because there is nothing palpable in at least in the anterior urethra as we know from the investigation, and the meatus is normal. However, one cannot be sure just based on examination about the urethral stricture. And the fourth would be a ureteric stone, sir.
Okay.
Aditya, how common is bladder stone at 36 years of age?
Sir, it is not very common. Usually the age groups are either pediatric or geriatric secondary to bladder outlet obstruction.
So then why keep an unusual diagnosis as first diagnosis?
Sir, actually of the differential diagnosis that we have, nothing typically fits into a young male with hematuria and the kind of lower urinary tract symptoms that he's having, which are largely storage symptoms with strangury. So, which is why I would put bladder stone ahead.
would you not think that Geocox probably should be the first diagnosis?
Yes, sir. That would be right. That would be a important difference.
So with this presentation where there is increased frequency, lower urinary tract symptoms, clinically nothing palpable or nothing found, in our
Yes.
country, Geocox should be something which we should keep in mind much
Yes.
before stone or bladder tumor.
Yes.
Okay.
Sir, I'd like a complete blood count, creatinine, urine routine microscopy, uroflowmetry, followed by ultrasound KUB with PVR.
Bus.
So as the first investigations, this is what I would want, sir. Based on this, I will tailor the subsequent investigations.
Patient also has had hematuria. So now here to evaluate also as per the
Yes,
what is the cause of hematuria?
Yes, sir. So, sir, as a in gross hematuria, we can straight away go ahead with a CT, contrast enhanced CT scan, IVP. But if we do an ultrasound initially, it may help us eyeball what is the pathology. So I would first want to do an ultrasound and then tailor my CT scan based on what the ultrasound findings are.
But which is more specific, sonography or CT scan?
CT scan is more specific, but ultrasound as an extension of the clinical examination as well as a relatively innocuous investigation will help me tailor my CT scan in a better way, sir. If I find the presence of based on my differentials, if I find the presence of bladder stone alone, I may do only a plain CT scan. If I find the presence of a bladder mass, then I would like to go ahead with doing a contrast enhanced CT scan. If
Aditya, my simple
Yes,
question was, what
Yes.
are the basic investigation in patient having hematuria?
So the investigations are contrast enhanced CT scan.
Basic investigation.
So the basic investigation would be urine cytology.
Yes,
Urine
you were missing this one in your routine investigations.
Yes, sir. Yes, sir.
Right?
Yes, sir.
And young patient, old patient, you have to also do a serum PSA. But young patient, if PR is normal, so you can
Yes.
that serum PSA.
Yes. Yes.
Then sonography is okay. Your logic was okay, and urine culture also. Remember.
Yes. Okay.
So on urine routine microscopy, pH was 6.5, protein and sugar was absent. RBC was 20 to 25 per high power feed. The WBC was 5 to 7 per high power feed. Epithelial cell were absent, and no growth was seen on culture. The cytology was not. The blood reports are grossly normal. This is the ultrasonographic film of
Why Siam?
actually, sir, the X-ray was not done as patient visit came to the hospital late, so BP was directly taken of course, sir.
Right, Aditya?
Sorry, I could not hear. Sir, I'm unable to hear, sir.
Mahendra, you are not clearly audible.
Achha, I was just saying the X-ray KUB was not in the list of Aditya primary investigations.
Yes, sir.
So this is my query actually. Why the USG KUB was done? Yeah.
So Aditya, the question is that in today's time, will you insist on an X-ray KUB or you will first do a sonography or will you go for CT scan? What is your sequence of investigations?
Sir, my sequence of investigations is to first do an ultrasound. if I find abnormality, then I would straight away go for a CT scan, and I would skip the X-ray KUB, sir.
Fair. I think it is, Mahendra, this is an acceptable answer, or you have any other thought?
Yes, sir, right. But I think X-ray KUB is not needed at today's when we have advanced investigations like CT scan. The next, even non-contrast CT scan is very quick and without any harm to the patient.
Absolutely.
And it will cover whole abdomen and pelvis and it more clarity.
USG बोलना ही पड़ेगा, I think, as an extension.
yeah.
Sonography though is a must.
Yeah, is a
And
must.
based on sonography, what Aditya is saying,
I think-
probably acceptable to me that based on what he finds,
CT scan.
he will decide the type of CT to be done.
Right. I
Okay.
think so.
Sir, on the ultrasound, I can see the presence of a large hyperechoic area in the bladder, which seems like a bladder calculus with intense post-acoustic shadowing. And I can also see that the left kidney is hydronephrotic and the right kidney appears to be normal. The liver, as shown in the films that I can see, appears to be normal. And the lower ureter is dilated in the film that I can see in the bottom left corner, sir.
Bottom left corner.
Yeah.
Is it so in the report?
You see, Aditya, again here, more important than dilated lower ureter, I would say, I would talk more about the thickened bladder.
Yes. Okay, sir.
So, what is the normal bladder thickness?
Sir, in the empty state, the bladder thickness should be less than 3 mm. Sorry, less than 5 mm. And in
How do you measure it in empty space, empty state?
So, sir, when the bladder wall is normal, then we are unable to measure it. But a thickened bladder wall, even with small amount of urine, may be measurable. When the bladder is distended, at that time it should be normally less than 3 mm. So anything more than 3 to 5 mm in a distended state is abnormal.
So when you have to measure the bladder wall thickness, how much bladder should be full? At
Sir,
what fullness will you
much as-
measure? 100 ml, 500 ml, 300 ml, what?
Sir, as much as the patient, so that the functional bladder capacity of the patient at the minimum 150 ml would be appropriate.
So that means then for every patient, you will have a different bladder wall thickness. Because thickness will be more at 150 ml as compared to 500 ml.
Yeah.
So there has to be some guideline for that.
Sir, I am unaware of that.
Okay. So bladder wall thickness is always measured between 250 to 300 ml.
Okay.
So when you have to say bladder is thickened or normal, it is optimally measured at 250 to 300 ml.
Okay. Yes.
And it should be measured at least 3 different places,
Yes.
and a mean of that is taken.
Yes. Thank
you. Okay, go ahead.
Sonography reports both the kidney are normal. There is no calculus or hydronephrosis. Urinary bladder is suboptimally distended and show a thickened bladder wall with a wall thickness of 7 mm. Evidence of 8.3 into 8.1 centimeter size echogenic focus appearing to be within the lumen could be suggestive of a urinary bladder calculus. The pre-void volume is 110. Post-void shows complete emptying of bladder. Prostate is normal in size. Impression is thickened bladder volume with urinary bladder calculus.
सोनोग्राफी का फिल्म वापस लेना, इतना बड़ा स्टोन दिखता है.
Left.
Yeah, a huge stone is seen. Show the upper line. Yeah.
Yeah. Shadow is there. Shadow is there.
It's a different shadow only,
Hmm.
The arrow is pointing to the echo.
Yes.
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 So now Aditya, what next?
Sir, there's some hydronephrosis also that is seen on the left side. So my next investigation would be a CT IVU, because I'm not very sure that the left kidney is normal. I think there is something that is the left kidney appears dilated. So given that the patient has gross hematuria, the presence of a large stone, and left hydronephrosis, I would want a CT IVU.
So if there was only bladder calculus, how does it change your thought? What will it show you?
So with a bladder calculus alone, I would be happy to do only a non-contrast CT, because the purpose of doing CT in that case is mainly to see if there is any other upper tract calculus that we may be missing, which may not have been picked up on an ultrasound. So that can help us, because this patient at a young age has developed such a large bladder stone. So he may have propensity of stone formation. So that is the thing that I would want to check mainly. And that's
No, Aditya. So means because he has bladder stone, he is more prone to form upper tract stone. That is what you are saying.
No, sir. I want to see if there is any other upper tract stone. And he may have, since 3 years he's having this calculus. So I also want to see if there is any, because of a long-standing calculus, whether there is any mass that he has developed in the bladder, which we may be missing in the sonography because of the presence of such a large stone.
So more so the reason, you see, so that means more so the reason you should be doing a contrast CT and not a plain CT.
Yes.
Correct. That's what I think, that this should raise a more alarm in your mind rather than the stone. You know, the bladder wall thickness of 7 mm, and
Yes.
you would want to evaluate that more by a CT rather than saying that because there's a bladder stone, I want to look at an upper tract stone. I think this is a better answer.
Okay, sir. Thank you, sir.
So has the CT been done?
The CT was not done.
So let's presume that CT shows upper tracts to be normal and we don't find any tumor in the bladder.
Yes. So, sir, then because of the large size of the stone, I would first like to do a cystoscopy. And after my cystoscopic evaluation of the bladder size, the stone, I want to then look at the bladder for presence of any obvious mass that I can see in the bladder. And I also want to evaluate the outlet, because the patient has developed such a large bladder stone. So I would want to see the urethra. I want to see if there is any bladder neck, if the bladder neck is opening well. I want to look at both the ureteric orifices, and then go ahead with the surgery, which in this case I would like to do an open cystolectomy.
So why don't you do a uroflow to confirm all these things?
Sir, in the presence of a bladder stone, the uroflow will be fallacious in the presence of such a large bladder stone. The bladder stone itself will obstruct the flow of urine, so it will not give me a good idea.
Not will, can. You understood?
Sorry?
You should say bladder stone can obstruct, not will obstruct.
Yes. Okay.
Okay.
Yes.
And same would be the reason for not doing a urodynamic test.
Yes, sir.
Perfect. So what was done?
This is the cystoscopic view, and in the cystoscopy, the stone was too large to all the wall and VOJ were not able to see any of the ureteric opening. The plat.
So Aditya, we have a very large stone with bladder outlet which looks open.
Yes, sir.
So now you would want to do a
open systolic.
Could you manage this with any endoscopic method?
Yes, sir. We can manage this with a PCCL, a percutaneous cystolithotomy. That is also acceptable, but the stone is too large, and the procedure will be much longer, and the purpose of doing it with less morbidity will not be served very well. So, which is why I would like to do an open surgery.
I think absolutely justified. Anybody else has any question, please?
No question. With the stone being there, अच्छा, ये cystoscopy की view है.
Yes.
So what is the fallacy of cystoscopy in such a large stone?
So because of the presence of the stone itself, we are unable to actually evaluate the mucosa, the dependent part of the urinary bladder on which the stone is causing the
Correct.
maximum.
It's such a large stone, 8 centimeter. So you are unable to evaluate the bladder wall properly.
Let us, Hiren, let us think otherwise. Suppose this stone was 3.5 centimeters. What else you would have done in cystoscopy?
Sir, if this is 3.5 centimeters, then I would have been able to see. I would have first evaluated the outlet as I go in. Then I would have evaluated the capacity of the bladder. I would have evaluated the quality of the mucosa. If I can see any mass lesions, I would.
Why did you say capacity first?
So because the patient functionally has seems to have a small capacity bladder based on the amount of frequency that he is having. There's also some thickening
Aditya, sometimes you should take the lead from the examiner. When the examiner changed the scenario for you, I was keeping quiet.
3.5 centimeters. So
yeah, he's saying 3.5. Then why do you want to
see capacity?
Correct. Sir is trying to give you a hint that there is a 3.5 centimeter stone and the bladder wall thickness of 7 mm. Now, are you suspecting anything else?
So we are not suspecting contracted bladder. Again, if it is a long-standing stone, either the mucosa will be normal or the mucosa will be abnormal. What will you do if it is normal? What will you do if it is abnormal?
If the mucosa is normal,
and your scope is already inside with the 3.5 centimeter stone.
Yeah. So then, sir, I'll go ahead with a cystolithotreaty.
Cystolithotreaty. Okay.
With the 3.5 also,
3.5 is a huge stone actually.
Yeah, huge
for
stone.
A cystolithotreaty.
Correct. So, sir has given you 2 scenarios. Now,
so with an abnormal mucosa, I would not want to do a percutaneous procedure or.
So what would you want to do? Don't say what you don't want to do. What do you want to do?
So with an abnormal mucosa, I will go ahead with the cystolithotreaty. With a normal mucosa, I would be.
Aditya,
what will you do to the mucosa?
Aditya,
I'll take a biopsy. I'm sorry. I'll take a biopsy. I'm sorry. Yes, sir.
Abnormal mucosa is there. Probably you will take a biopsy and not do anything. Probably.
Yes, sir.
Maybe you will put a catheter and come out.
Yes, sir.
And as you said, you will look into if orifices are seen or that abnormal mucosa is covering those orifices or something like that. If it is normal, bolo abhi kya karoge? Like a urologist, what will you do if the mucosa was normal all over? Now.
So what is your fear, Aditya? Sir is asking, there is an abnormal mucosa. What is your fear?
My fear is that if it is a malignancy and I do an open cystolithotomy or a percutaneous procedure.
No problem. If you fear or suspect a malignancy, give a good biopsy, put a catheter, explain, counsel, and come out. Wait.
Yes, sir. Yes.
But if it is normal now, what you will do? You have so many methods of stone extraction. So what will you follow?
Sir, with a 3.5 centimeter stone, I'll follow I would do a PCCL, which is a percutaneous cystolithotomy, and with an 8.5 centimeters, as in this case, I would do an open cystolithotomy.
Open cystol. Okay, so 3.5, you do a PCCL. What energy you use to break the stone?
Sir, if available, I would use an energy source, like a combined energy source, like a shock pulse, which would help, or a lithoclast with suction, which would enable the fast breakage of stone. And along with that, I would keep a large amplats sheath that will help me quickly extract the stone.
It is also a
Amplats
good
sheet
idea to
where?
keep something. Where, sir is asking, amplat sheet where?
No, so for the PCCL, sir, for the PCCL,
Right, so
suprapubic
it
amplats
is
sheet.
also,
suprapubic, for the suprapubic approach, sir.
it is also a
And
good
I will
idea
also-
to have a help down and put a cystoscope, 25
sir.
sheath or something. Or it is good to give washes. It's easier. It's
Yes,
not so easy to give a wash through PCCL.
Yes, sir. Yes, sir. Yes, sir.
So if you said you will use either laser or whatever that lithoclast, pneumatic, right?
Yeah, pneumatic or the ultrasonic combined with pneumatic and suction.
Correct. So if you use a laser in the PCCL, what will you exactly do with the laser?
So I'd like to fragment the stone if I use a laser, and
I don't know. We'll need Dr. Pankaj sir ka help here.
Aditya, I think that you should not say laser when you're doing PCCL.
no, sir.
That we could have achieved from down only, no?
Yes, sir. No, no, no. I
Lithoclast is
don't
much
say laser.
faster. The purpose
Yes,
is
sir, yes,
that we are wanting to do it faster, no?
Yes,
If we
sir.
had
Sir,
to
I
do
didn't,
laser only, why would we make a puncture?
yes, sir. Yes, sir. I didn't say laser. I don't think we should use
Yeah,
lasers.
I think you should say trilogy. You said that, so you said I will use the
Yes.
new technology.
Yes, sir.
It's faster to do it with a PCCL.
Yes, sir.
Would you get a metabolic evaluation done for this patient?
Okay.
So he's a first-time stone former, and I would do a basic stone evaluation, which would be serum calcium, uric acid, and phosphorus, and then keep the patient on follow-up to see if he actually develops another stone again, because he may, since he's a first-time stone former, doing an extended evaluation is not indicated in him as of now. I would, however, discuss it with him, and if he's keen on doing it, then since as a first-time stone former with a very large stone, and if he's keen on it, then I will go ahead with a urine metabolic workup once the stone is completely clear. And
What is the genesis of stones in bladder?
so, sir, the stones in bladder may be because of obstruction to the outlet, infection, or they may have dropped down from the upper tract. In children, they are usually because of malnutrition.
Any other causes?
So there are three terms for bladder stones.
So, sir, the secondary would be secondary to an outlet obstruction.
पहले primary बोलो ना भाई.
हाँ, sir. Primary would be the stones that are formed without any evident cause that have dropped down from the upper tract, and secondary would be because of the presence of an outlet obstruction or infection.
And what is migratory?
It is not like that.
It is not like that.
Primary is without any known abnormality in the tract.
Yes, sir.
Migratory is the stone migrated from the above. And secondary is with a recognizable etiological cause. Okay. Then again,
When you are doing well, you should be very clear with classifications.
in causes also, there are infection, neurogenic bladder, bladder obstruction, foreign body, prostatic enlargement, and stricture urethra. These are the more common. And in pediatric, these are usually the primary stones due to low socioeconomic status and dietary problems.
Yes, sir.
And in endemic areas.
Yes.
As far as treatment is concerned, one important point you should be in your mind while selecting the treatment is the Huntsville unit of stone. Suppose 3.5 centimeter stone with Huntsville unit of 500 or 600. So you can tackle with cystoscopy cells using.
Yes.
Okay. If it is 1200 and 1300, then PCCL. So size and unspilled unit of stone. These are the two factors in anatomy of the tract for access. These are the three factors while selecting the type of treatment.
Yes.
Current new some literature about the large stones like this 7-8 centimeter along with open cystolithotomy. There are few papers on robotic cystolithotomy.
Okay.
So if
So
examiner
this-
ask, is there any recent newer advances in the management of bladder stone with huge large stones? So you keep in mind, if examiner ask only, then only tell. Otherwise, don't tell.
Yes.
So this completes your answer. At the same time, you should also talk about the volume of the stone. There's a lot of work right now in volume of the stone rather than just
Yes.
2 centimeter, 3 centimeter. Even in RIS, they are talking now about volume.
Yes, sir.
Okay, so now Paras, I think we should go back to the original scenario. What it is a 8 centimeter stone. So what was done?
Paras, what was done? Just tell them. Okay, so TCCL was attempted, difficult to do anything. Okay,
Yes.
and so ultimately open up the patient, remove the big stone fragment, everything. Again, did a scopy also at the same time. As you can see, it is very hard. Okay, fine. So after removal, Paras, just show them what you saw.
Open stone removal.
Yeah, because even PCCL from suprapubic also, it was very difficult to break the stone. So ultimately, we decided to open up and remove the stone. So now after removal, can you see
Yes.
growth inside?
Yes, sir.
Yeah. So what you will do now?
Sir, I would like to biopsy this growth. And
And how will you close it?
Maybe send it for a frozen section.
yes. Yes.
It will have a lot of complication. You will have pros and cons for the answer.
Yes, sir.
And what you will do? How will you close it? You will do closer with a suprapubic, without suprapubic. How will you close it?
No, sir, I will not put a suprapubic. I'll put a drain. I'll close it. To close the bladder, I'll take a biopsy.
Okay. So the question over here, I will put it to Mahendra and your this thing. What advice you give, Ganesh, when such a scenario takes place?
Sir, the
Number one is that
I saw that problems are going to be that we have taken the patient in the OT with the thought of only doing the stone.
Correct.
If it comes something which we suspect like squamous cell, because large stones can be associated with squamous cell, which is itself a variant histology. So the treatment with that goes straight forward to a cystectomy, if feasible. So in this patient in whom I have taken under anesthesia, young patient, 36-year-old, with the counseling of stone extraction open, I don't think I'll be able to do a cystectomy. So I need to maybe do a frozen section, also keep a sample for histopathology and properly close the bladder without SPC. We will have to see the histopath.
How will frozen section help her? Why are we doing frozen section?
It will just help in actually telling the relative at the OT counter that we saw the mass. I have sent the proper histopath, but this is a squamous cell. And since we had not discussed anything about whatever neobladder conduit, total removal of bladder, which is a very ghastly surgery or which is a mutilating surgery for a young person. So we are not going ahead in this surgery with the treatment, but subsequently we'll need. I think frozen will help in just counseling, probably. That's why I said we'll obviously send a histopathologist.
So my question is that in the exam, to start with investigation, in any such case, is it mandatory to talk about CT scan, or you can go directly with a ultrasonography and X-ray?
Sir, Abhi, I don't know. Matlab, if this big growth is there, it will get suspected in the CT scan. But in this particular unusual case, the bladder calculus was too big.
Okay. So it is.
It was not giving you any, I mean, space only.
So
Actually,
as
sir,
a Pankaj, as a general urology, which we are practicing, you, me, Hiren, and Gite sir, in our practice as an examiner, what you will expect? You will expect a CT scan, or you will not ask for a CT scan?
Sir, I would expect a contrast CT scan. The reason
Okay.
being, one, it's a long history and a history of multiple episodes of hematuria. Now,
I agree.
because of just based on such smooth large stone, I would really not expect hematuria to be a predominant symptom. Possible, but when patient has such extensive hematuria, I would definitely want to investigate further.
Fine. So in
So I
exam, in
guess
such cases,
seconding what Dr. Pankaj sir has said, no, students, you should always remember that when that hematuria thing is there, as a extension of bedside or a palpation, we can always ask for a sonography. And please don't forget that urine routine, cytology, a CT scan, and a cystoscopy. I think hematuria, we mandate everything of that.
Any patient who presented with hematuria and not having any obvious cause, a person should go for ask for CT scan. One. Another thing is all the bladder stone usually associated with upper tract stone. Sonography is not a good investigation for doing the evaluation of rest of the stone. So again, there is a need of non-contrast CT scan. Whenever there is a huge bladder stone, there are chances of having associated malignancy. So that is one indirect indication for CT scan. So in such type of patients, we have to go for contrast CT scan.
Yes.
Now the question is, in this type of, say, large stone, had we done a CT scan, seen the sort of thick bladder wall and a thicker abnormality, I mean, this was too large. I mean, your scope was going for a biopsy also, probably. I don't know. I thought so.
Assessing the all walls of the bladder in such a large stone is difficult, but not impossible. That is one thing. Another thing is if CT scan suggests of, suppose for example there is a thickened wall on left side, thickened wall on right side, some clues in the CT scan, then you have to search particularly for that particular site.
Any other opinion from anybody?
Sir, can I add something?
Yeah, why not?
So in this, you rightly said cytology has a role. Suppose that a cytology is positive. So definitely before opening the case, we should do a cystoscopy first to see any lesion in the bladder. As Gite sir said, it is not impossible to see the whole bladder wall, and we can take a biopsy and we can postpone till the biopsy report is there. In second scenario, if cytology is negative and we perform this surgery, as Dr. Bakshi sir said, that is the proper approach. So as per two scenarios,
इसमें cytology में थोड़ा सा problem हो सकता है. मतलब it may not be typically like urothelial shedding the cells type of cytology.
But sir, if it is there positive for cancer cells, and cancer cells by the experienced pathologist,
I agree.
Right, so it can differentiate. We are dealing with something other than the stone, so our approach will different. Okay, Aditya.
Yes, sir. Yes,
I
sir.
think
Thank
you got the message. Everybody got the message. How to approach these cases. Okay.
Yes, sir.
so now,
But
okay,
remember,
Mahendra, go ahead.
As the Ganesh said very rightly, without taking any consent, never proceed medical legally.
Yes.
Okay.
Yes, sir.
Yeah.
Fine. So Paras, just go ahead. Just tell them what we did.
biopsy came out to be invasive squamous cell carcinoma. So we put
And-
a perimetral catheter and a suprapubic catheter.
See, because the suprapubic was done and the incision was little lower down, whatever it was, and so suprapubic was also kept. So now, Aditya,
Yes, sir.
you have got a suprapubic, you have got a drain, you have got a wound, and you have got a periurethral catheter. How will you manage?
So,
And
sir,
this
now,
patient has, the diagnosis has come in within 48 hours, we got a diagnosis. It's a squamous cell, invasive squamous cell carcinoma.
yes, sir. So, sir, now I would like to counsel him that he requires a radical cystectomy, and I will counsel him for the choice of to go between a neobladder and an ileal conduit. Since he's young, he may be compliant, and I will offer him a neobladder with explaining the pros and cons of both the ileal conduit as well as the neobladder. Along with the radical cystectomy, I will also do an excision of the site of the suprapubic catheter as well as the previous incision that I have placed.
CT scan अभी तक हुआ नहीं है ना patient में?
Sorry.
Without
Sorry, sir.
doing that, how do you
Yeah.
know the planes are good? This squamous cell carcinoma might be just pericycle.
Yes, yes.
See, Aditya, number one, what Ganesh has said, that is also right. But first, what you will do, how will you treat him? Whether you want to remove, keep the suprapubic longer, you want to remove suprapubic earlier, one number. Second thing is when you remove the periurethral, and second thing is whether patient is agreeing or patient is not agreeing. He is such a young patient, he is not prepared for this. Suppose he says, no, I don't want to undergo surgery. Now what you will do? So just tell us when you will remove the suprapubic, when you will do the polyurethral, when you will do CT scan, and both the scenario. Ganesh and Mahendra is there now.
Yes.
To
So,
take
sir,
you.
I would not remove the suprapubic or the periurethral catheter immediately right now, since we have already put it. I would evaluate the patient, as sir said, with a CT scan. I would do X-ray of the chest as well as a contrast enhanced CT of the abdomen and pelvis, and then depending on the counseling of the patient, if he agrees for the surgery, then I will proceed with radical cystectomy and lymph node dissection, a standard lymph node dissection with excision of the scar site as well as the suprapubic site.
Okay.
Aditya,
Mahendra.
this you should always say the disease status. Suppose that the spread is involving the rectal wall also. Then he needs the exaggeration,
Yes, sir.
right? So local
Yes.
extent of disease and the
Yes.
patient condition, his
Yes.
fitness. Okay, this should be in your explanation.
Yes, sir. I will.
An answer, in your answer.
Yes, sir. I remember.
Okay. So CT we have or not? No.
No,
You
no,
don't
not
have.
done. No, it's just this case is just few days back only. So
Okay.
yeah, okay. So now you ask him if he says no, what else you can do?
Sir, but एक चीज है मतलब if we had a doubt of say squamous or a urothelial, and then there was not too much of a bleed post stone extraction open, we could have avoided the suprapubic. No?
Right.
Yes.
I agree. Yeah.
Squamous में तो it is still okay, but urothelial तो we'll fully try to avoid मतलब, if at all we need to open the bladder.
Correct.
But even sir, if there is a no bleeding inside the bladder, even we can avoid suprapubic.
Suprapubic.
Yeah, so in this case, suprapubic could have been avoided, and but because
Avoided.
originally patient had a bleeding, so in anticipation that it may, and then we saw the lesion, in anticipation that post-operatively, if already the open surgery we have done, and if the patient develops the bleeding, then there will be lots of problems. So in that anticipation, It was checked. And sometimes it comes in your mind. You always try to believe, okay, it is not the worst scenario. It is just because of the stone. All these things have taken place. It is not carcinoma. It is just the inflammation.
So
Like
one
that.
thing, Aditya, you
Yes.
said tract excision वगैरह. So urothelial carcinoma is the one which causes seeding.
Okay.
Okay. So
Yes.
it may not happen with the other variants.
Okay, sir. Okay.
So urothelial, we definitely need to excise the tract, or if somebody has put a PCN in the upper tract urothelial kidney, I would still excise that tract right from the skin.
Okay, sir. Okay.
Okay, but in others, it may not be technically needed. You might get away like.
Right, sir.
Okay, so
So Ganesh, what I have understood is that if it is a squamous cell carcinoma, then the chances of seedling and the involvement of the tract and suprapubic tract, so there are less chances. Correct?
right, sir.
Okay. So that is a good thing. So, but we have to excise the full tract,
With urothelial, we excise, sir.
but not in squamous cell carcinoma.
Squamous cell, it's not going to seed like the urothelial ones unless the cancer itself has grown somewhere in the tract. You can cut it with a safe margin.
Okay. Now,
Squamous cell carcinoma is always with a safe margin.
okay. Now the second question is that in this case, second opinion, number one, the re-evaluation of the slide and the check cystoscopy is necessary or not necessary?
Second opinion with the histopathology.
What with the histopathology?
So that depends on, very honestly, on how confident is the histopathologist.
Okay.
If somebody good is there, then I may not need a second opinion, because see, histopathologist is also liable to the diagnosis what they give. If today they give common and after you do the cystectomy, they say no, it was urothelial, then it is their problem.
Okay.
One
Then
more thing.
check
One more thing, sir.
cystoscopy is necessary. What, like check cystoscopy again means after before confirming again you go inside and take the biopsy. Is it necessary or it is not necessary?
If you already have a biopsy proper, then saying something, then it is not necessary.
Okay.
Because on presence of variant histology, you are going to treat straightforward in a different manner than urothelial.
Okay.
Mahendra, you want to say something?
Yes, sir. Just when, as you said, if suppose that when we open the bladder and we see this is a solid mass or having the involving the bladder wall dense tightly, and the biopsy report comes a low grade, then definitely this is things are not matching. Then again we need to have second opinion. But if it is a high grade or something, then there is no need for any second opinion.
Okay. Now this patient has refused surgery. Aditya, in short, you tell us what are the different ways, and so we'll confirm it with Ganesh and Mahendra, and then we'll go to the next case.
Sir, any other form of treatment will be suboptimal, but I will again do a cystoscopy, do a resection of the mass, and then subject the patient to radio CTRT, that is chemotherapy and radiotherapy, since it is a squamous cell carcinoma that has been diagnosed.
But again, you have to explain and document it.
Yes, sir.
You have offered the best treatment, available treatment for the stem cell carcinoma of the bladder, and patient refused for the surgery, and he knows that this is the not optimal treatment. Chances of disease progression and regression are very high without this treatment. And then whatever so his organ, his body, he's the right person, only person who can choose that.
Yes.
So the documentation is the most important thing in this case, right, sir?
Yes, sir.
Right.
And the Mahendra, the last question, in this case, when you will do CT scan?
When, sir?
Sir, follow up or what?
Yeah, no.
Sir,
after the surgery, in this case, we have not done CT scan earlier. So how early you will do CT scan?
Sir, after the cystolithotomy
yeah, after open cystolithotomy.
Sir, because we have opened the bladder wall anteriorly and tumor was posteriorly. So that is not going to affect the plane posteriorly. So even after 10 days, we can do that.
Okay.
But
Fine.
if the site of tumor and the where we open it is same, so again we can wait for at least 4 weeks.
Oh, so this answer, all the students should know in the exam.
Yes.
Fine.
But
Okay.
one more thing, if suppose that you open the bladder where the tumor is it not sure muscle involving or not? So CT scan may be not informative in this scenario. So maybe the MRI after 2 weeks, 3 weeks will be the better option.
Okay. Fine. Paras, the second case.
Thank you.
Yes, yes.
So
Second case-
what lesson we took from this case? Adit, can you just in 1 minute?
Yes, sir. For evaluation of any gross hematuria, we should do a cytology, contrast enhanced CT scan. Before doing an open cystolithotomy, we should try and evaluate the bladder, especially in with a long-standing history. We should try to evaluate the bladder ideally by a CT scan and then followed up with a cystoscopy. And urine cytology is mandatory while doing these things. If at all we do end up doing an open surgery in an inadvertent situation where we have missed on our pre-op evaluation and we have done an open procedure for such a situation, we should close without putting a suprapubic tube if there is not a significant amount of hematuria, and then subsequently proceed with the counseling of the patient and the treatment. Also, not to forget the metastatic workup and complete workup of tumor before proceeding for surgery.
Okay, and proper consenting from the patient, and not to operate anything which you have not considered, which is major one. Okay. Someone asked in a chat box, can we wait for 4 weeks for CT scan in the CA bladder? So if suppose that whenever we open the bladder from the tumor site, definitely we are going to take a biopsy from that site. If suppose that that tumor is muscle invasive, we can do immediately CT scan and proceed, because our main purpose to localize the disease staging for local staging and therefore metastasis. So in that case, because we know the site of tumor, we can perform CT scan in a week when the patient is stable, and we can plan for surgery after that. Is it not mandatory to wait for 4 weeks? It depends on the case scenario.
Yes, sir.
Yeah. Now you can get next case.
Okay. Thank you, sir.
Paras, next case you take the ruptured ileal conduit, huh?
You've done well, Aditya.
Yeah, Aditya.
Yeah, right,
Paras,
right.
second case will be ruptured ileal conduit. So
Yes.
that Ganesh and they are, can evaluate. And then last will be obstructive uropathy. Okay?
So we'll take this quick, no problem. So all will finish in by that time.
Okay, fine.
Dr. Nair.
Yes, sir. Share.
Second case, a 72-year-old gentleman with a surgical history of radical cystectomy with left nephrectomy with ileal conduit presented to the emergency department with history of pain and distension of abdomen since 7 days, no output from the ileal conduit since 3 days, altered mental sensorium since 2 days. Patient presented to our emergency with a sudden onset generalized colicky pain in abdomen with increasing severity associated with gross distension, nausea and vomiting, non-radiating, non-referring, aggravated on movement, and was slightly relieved on medication. Patient also have decreased renal output from the ileal conduit progressing to nil since 3 days. Patient was able to pass flatter seizures initially, which was later on converted to obstipation. Patient has a history of altered mental status since 2 days, which was not associated with seizures, focal neurological deficit, headache, or a syncopal attack. For past medical history, patient underwent a left nephroureterectomy with radical cystectomy with prostatectomy with an ileal conduit for a muscle invasive bladder cancer involving the right ureteric orifice and a trigone. with a non-functioning left kidney 2 years back. Patient is known case of hypertension. There's no history of ischemic heart disease, pulmonary tuberculosis, asthma, or diabetes mellitus. Personal and family history, they are not as such contributory. In the examination findings, BMI was 30.24. At the time of admission, the blood pressure was 150 by 90. The saturation was 98% on 4 liter of oxygen support. Pallor and bilateral pitting pedal edema was present. There was no evidence of actus cyanosis, clubbing, or lymphedema. In the per abdomen examination, abdomen was distended, umbilicus was central and inverted. Ileostomy with normal color and texture was present in the right iliac fossa region of the abdomen with no contained discharge. Midline heel scar mark of previous surgery was present. No visible lump, peristalsis, pulses, or engorged vein was seen. No renal angle fullness was noted. On palpation, local rise of temperature of the abdominal wall was present with a generalized tenderness with rebound tenderness and guarding. No hepatomegaly, no splenomegaly on deep palpation. Parastomal swelling, soft in consistency, compressible, non-reducible with a palpable bowel luge present. Genitalia and what not? Genitalia and on percussion, there was a dull note present over the abdomen suggestive of fluid collection. Auscultation, the bowel sound were absent. In CNS, the patient was not disoriented. He was not oriented to time, place, and person. G phase was 13 by 15. Pupil were bilateral reactive. In respiratory system, there was a decreased entry with bilateral cracks in the basal region.
Well, history and examination.
Yes. Yeah. In inspection, abdomen is distended. Ileostomy was normal.
नहीं ये हो गया ना ये पढ़ा है.
Yeah.
It is done.
Okay.
Who is answering?
So where do we come? Already we have lot of history and something. So what is the likely scenarios?
Sir, I wanted to ask that whether the patient was like post-operatively, patient was fine, and then he was discharged, and like I want to know a little bit more about that timeline of the patient. Like after the operation, how was he? He was well and he was passing flatus. Then he was discharged, and when he presented again, so that I wanted to ask.
Surgery was done 2 years back. Patient was discharged with stable vitals.
Okay, so 2 years back he was fine in between, and suddenly that gush of whatever happened.
Okay.
पता है उसने.
Something is important in the history. Something important. Nayan. History and examination. Something is there which you should ask. This patient must be regular follow-up, right, Paras?
No, sir. The patient is from remote area from Assam. He was lost to follow-ups in the plan.
Okay, so after surgery, he came with this condition, right?
Yeah, yes.
Okay, fine.
ठीक है. तो क्या हो सकता है बाबा?
चलो नयन बताओ, as per the history
बोलो.
examination.
For abdominal examination, sir, it seems like patient has got intestinal obstruction. A mechanical intestinal obstruction might have been there, resulting into the peristomal herniation of the bowel.
Nayan,
Yes, sir.
after listening the story,
Yes, sir.
is this patient is suggestive of the clinical findings suggestive of obstruction or perforation? Simple general surgery question. So how will you differentiate the perforation peritonitis from obstruction?
Paras, go one slide back. Examination, one slide back. Yeah. Now you, Nayan,
Yes, sir.
now you see. Gita sir asking something which related to this slide.
I think, sir,
Right,
it is
sir?
most likely to be a perforation because patient is having rebound tenderness as well as guarding was there, sir.
Obviously. So if the patient presented with guarding rigidity plus minus distension,
Yes.
pain, it is indirectly suggestive of perforation.
Yes, sir.
So perforation may be of anything, maybe of small bowel, large bowel, or probably that he has a history of ileal conduit, so that some problem may be related to that conduit. So these are the probable things one can, because it is associated with decreased output also.
Yes.
Barabar.
So after considering the story, something is with the bowel.
Yes, sir.
So as he has a history of ileal conduit,
Yes.
so how will you rule out the conduit? There is a conduit problem or there is no conduit problem?
बोलिए नयन.
Sir, first we can go. We have to just go for some basic investigations in form of blood investigation. After completing that part, we can go for the investigation part, sir.
Okay. So your clinical diagnosis is perforation peritonitis.
Yes, sir.
So just I want to know how will you plan which part of the bowel is what perforated? How you diagnose?
Sir, to rule out the GI tract, sir, we can go for plain CT abdomen with oral contrast. And first we can rule out the part of ileal conduit. Then we can do a lupogram.
Okay.
Lupogram can be done. So if we clear out about the ileal conduit, if the patency of the conduit is normal, then we can plan for CT abdomen with oral contrast, considering like we have to get a creatinine of the patient. If creatinine is raised, then we can at least go for a oral contrast and CT abdomen examination, sir.
Correct. So the pouchogram or lupogram is a investigation to diagnose the problem related to the conduit.
Yes, sir.
And suppose this patient had a problem related to the conduit. So what are the clinical findings when there is a conduit related problems or conduit perforation?
Conduit related problems would be, sir, in the history part, we knew that patient is not producing any urine from the conduit since 2 days. So that will
So there is decrease in output. Number
Yes.
one. Number two.
Then, sir, if that urine is getting spilled into the peritoneal cavity, then the signs of uremia would be there because of the absorption of the.
So second is urinary peritonitis.
Yes, sir.
Number three. Elevated serum creatinine.
Sir, then there would be changes of edema, pedal edema, and water retention might be there.
Delayedly, there may be sepsis.
Sepsis, sir.
All signs of sepsis.
Sepsis.
Okay, so peritonitis, pain, low output, elevated serum creatinine, distension after some times, and full-blown sepsis.
Yes.
These are the probable clinical presentation of any bowel perforation. It may be conduit or it may be not conduit. So you have to do first serum creatinine and pouchogram.
Yes, sir.
Correct? Or lupogram.
Yes.
So सर और कुछ ऐड करना है तो बताओ सर बीच बीच में, क्योंकि मेरे से जितना बनता है उतना कर रहा हूँ.
Sir, only CBC for an infection.
Yeah.
So as per the antibiotic can start, and before doing CT scan, anything you can give that antibiotic as per the serum creatinine, either normal or renal dose. You can do that.
Correct. Correct. So जो भी है इन्वेस्टिगेशन बताने वाला है बताओ.
The blood report hemoglobin was 8. The total leukocyte count was 31,860. Polymorph were 82%. The serum creatinine at the time of admission was 6.58. Potassium was 6.1. The procalcitonin level was 8.61.
So Nayan, if I ask you, what is the can be a cause of serum creatinine 6.58 when the patient has got ruptured, maybe query ruptured ileum? What is the cause of this serum creatinine of 6.58?
Sir, as patient was lost for follow-up since 2 years, but this creatinine looks comparatively high rather than it as compared to the AKI. Might be some component of obstruction, or like there the upper tracts might have been compromised, or because of that this much creatinine might have been there, sir.
So that is one reason. In this scenario, what is another reason for rising creatinine?
Sepsis will also lead to the acute kidney injury.
Any other reason? Patient had a peritonitis. Why there is a peritonitis?
Sorry, sir, last part I did not get it.
Why there is a peritonitis? Is anything related to that urine inside the peritoneum which may increases the blood urea as well as serum creatinine?
It might get absorbed from the peritoneal cavity. That might also give rise to uremic symptoms. Might be because of that, sir.
So it may be de novo resident serum creatinine. It may be due to the sepsis, or it may be due to the absorption of the
urine.
Urine by the peritoneum.
The important thing in this, yes, sir. Please go ahead, sir. Sorry, sir.
No, bolo.
Only thing is that the urea is mildly elevated. Very, it's only 45. So normally in creatinine 6.58, where kidney may be the cause, you will never find the urea of a normal range. It should be 80, more than 100. So again,
Correct.
as sir said, that kidneys are not this thing got hit in this case. This is the what sir said, the absorption of the urine for maybe 2-3 days, maybe week, that get absorbed in the system circulation, and that may cause this high creatinine level. Okay.
Yes.
And second thing I want to that for your knowledge, because conduit maybe this is the this refluxing anastomosis. Okay.
Yes, sir.
So before any conduit to get rupture, there will be a good amount and time of the obstruction that may cause reflux of the urine into the kidney. Okay, obstetric uropathy that may cause this type of high serum creatinine. But again, in that case, your urea will be high. Okay. Yeah. Fine.
So pauchogram किया है?
No, sir, CT was done.
Okay. बता दो.
The X-ray of the patient.
Just show all the investigations.
Yeah. A portable ultrasonography. A patient was shifted to ICU in view of his unstable hemodynamics. So the ultrasound was done, which is suggestive of absence of left kidney due to nephrectomy status. The right kidney is 11 into 6.8 centimeter. There is moderate hydronephrosis with proximal hydroureter. Rest ureter is obscured by the overlying bowel. There is a interbowel collection noted in the infraumbilical region. It measures about 600 cc in volume. This collection shows a presence of few thin septa and low level of internal echoes, raising the possibility of infected collection. These were the CT films. This was a
sonography report.
This is the sonography.
Yeah. Okay, fine.
With a absent left kidney with a moderate hydroureter necrosis of the right kidney and a 600 ml pelvic collection. These are the CT.
Okay, next.
This is the delayed film taken 12 hours after this.
So if you are not going for pauchogram or lupogram, one must has a delayed CT scan. Otherwise, you may not able to identify the extravasation of the contrast outside the lumen of the bowel. If you do a standard routine protocol CT scan. So if you are suspecting a conduit related problem, in spite of going for CT scan, it is better to go for a lupogram first. If lupogram is not suggestive of anything, then the second investigation will be CT scan.
Okay, sir.
Yeah. Yet, Nan, what next? You have this image. What do you think?
So what first I would like to know about the basic resuscitation of the patient, as the pulse rate was very high and even he was having an altered mental status, and considering the altered RFT panel as well as sign of sepsis, I would like to first resuscitate him from the hemodynamical point of view, sir.
You don't want the CT scan report?
Yes, sir, that I want, but just before this.
Yeah. Okay. Okay. You have to, very good. Very good. You have to stabilize the patient, right?
Then, sir, I would like to go for, once the basic hemodynamical stability, we come to that, but then I would like to go for, as in this case, lupogram was not done, but CT, I would like to know the report of CT scan, sir. Sir, if it is possible, then we could go for CT lupogram first, and then we can go for oral contrast. That could have been done, sir, at the time of CT also.
Yeah, Gite sir told na, as per the doubt of the degree of doubt in a scenario, you should go ahead accordingly.
Yes, sir.
And even we also prefer whenever there is acute abdomen and a patient have conduit, so we always do lupogram first. Then because the bowel, sometimes the bowel contrast may overlap with the leak from the ileal conduit.
Yes.
Can we see the CT scan report? Nayan, Paras?
Yes, the CT scan reports was suggestive of an ileal conduit was seen in the right ileal fossa. The ileal conduit appears.
थोड़ा zoom करेंगे report को?
Yes.
कर सकते हैं?
Yes.
Yeah. The relevant part.
The ileal conduit appears dilated, measuring up to 3.6 centimeter in the maximum diameter, with a focal narrowing of the conduit seen at the level of right anterior abdominal wall. There is a leak of excreted renal contrast leading from the dilated ileal conduit into the peritoneal cavity. There is a resultant loculated fluid collection if in the infraumbilical and the suprapubic region of the peritoneal cavity, about 13 into 4 into 9.8 centimeter in size. Mild degree of right-sided hydronephrosis with delayed excretion of the contrast on the right kidney. No obvious focal narrowing or intrinsic calculus noted in the right kidney.
So, Nayan, bolo.
Something is missing in the CT scan report, Nayan.
So there is a peristomal hernia with fluid bowel ileal loop at the level of ileal conduit.
So,
did they mention the size?
Oral contrast was given?
Yes, sir, oral contrast was given. So in the oral contrast, there was a jejunal and ileal loop were seen dilated up to 4 centimeter. And there was a transitional zone in the mid and proximal ileum. They have seen dye reaching up to the mid ileums.
Okay.
So here there are four problems. One is patient general condition, signs and treatment of sepsis, then treatment of peristomal hernia, and treatment of perforation.
बराबर. तो क्या करेंगे?
क्या करेंगे बोलो?
पास बोलो, वैसे शॉर्ट केस डिस्कस कर रहे थे ना?
We should go for after this, after the initial stabilization of the patient, we have to go for exploratory laparotomy, sir.
Okay.
Because I'm suspecting there might be a presence of a band or something like that, which might be compressing, like which might be obstructing that ileal conduit, so that the proximal part of the ileal conduit might have been just popped up because of that band or some additions, or I'm suspecting some additions in this kind of situation, sir.
Yeah, but 2 साल कुछ हुआ नहीं ना.
Sir, sometimes these additions take some time to form because it is a chronic patient. Once the abdomen was opened at previous surgery, then we might have to it can happen anytime, sir.
वो तो बराबर है. Anything can happen anytime. But then perforation का etiology.
So that's what I'm thinking, that the mid part of the ileal conduit might have been compressed with some band, so it might not be draining from that external stoma, and that collection of the urine which is getting accumulated into the proximal part of the stoma where the ureteroenteric anastomosis is there, it might have just given off, sir.
So you have to explain like that. There may be any intraperitoneal adhesions which may be compressing the lumen of the loop, ileal loop, and due to that compression, there may be over distension of proximal to the compression, over distension and lateral perforation.
Yes.
Correct. That's what you want to say.
Yes.
So, as far as the very rare and few reported cases in the literature, and majority people have seen in numbers only. So it is either a spontaneously ruptured ileal conduit is reported. Then during doing the loopogram also, while filling the loop, there is a traumatic perforation. So there another cause is trauma. Then one is spontaneous, another is trauma, third is intraperitoneal adhesions compressing to the mid part of the loop. That is increasing the pressure. And usually whenever there is a more neobladder, so the neobladder is more prone for spontaneous perforation than the ileal conduit. And the common pathology behind both is over distension of that particular neobladder or ileal conduit. Another thing, I have seen spontaneously ruptured normal bladders because particularly the causes given is intramural infections, which may make the wall of that particular site fragile and prone for perforation. So intramural is infection, chronic ischemias, these are the reported causes. So if someone asks in exam, these are 4 or 5 causes, you should tell in exam. So chronic ischemia, intramural infection, trauma during doing the lipogram, spontaneous perforation and intraperitoneal adhesions.
Yes.
Whenever there is a frank signs and symptoms of peritonitis and sepsis, and if it is there is a contrast extravasation outside the loop, no other treatment than the exploration. But in properly selected patient with minimal extravasation, in the drainage of the conduit with antibiotic, there are reported cases with the conservative treatment.
Fine.
Bolo sir,
So-
aur kuch honga bata do.
Yeah. Now, finally, in this case, what are the role of PCN, because it's a solitary kidney, exploration and only doing ureterostomy, or doing it the anastomosis? What you will like to do?
Sir, from urinary point of view, we can go for end ureterostomy, sir, because there is a adequate dilatation of and hydronephrosis and hydroureter might be there. So that would be the one optional thing, because once we opt for the procedure, then we have to go in fast and be fast. Like it would be we have to keep the operative time as minimal as possible, and to deal about like that peristomal herniation, we have to take care of that thing as well as.
Okay, Ganesh and Mahendra, just tell your final answer, how you will tackle this case, and we'll go ahead.
Sir, gross ascites will explore.
Yeah, you explore. Then
We'll have to see मतलब perforation अंदर से कैसा है. If it is
Okay.
like, if it is totally bad, then it is better to, within the peritonitis and everything, just bring out a ureterostomy, which should be done in a good way, so that there is no stenosis.
Okay.
If things are okay, looking better, much better, then there is a chance of whatever suturing or trimming and then doing a reanastomosis. But inflamed ileum पे करना थोड़ा danger रहता है.
Correct. So the best bet is to exploration, remove all the urine, whatever is there,
Yeah, give a lot
put
of
a drain,
warm
yeah,
saline water.
and ureterostomy. And if you think that you are able to do the suturing of the ileum conduit and do
That
the
will be a
reanastomosis,
clinical call in draw.
yeah, then I think PCN is better, correct?
मतलब
that
कुछ
case-
नहीं तो first line is very good.
Yeah. Okay. Fine. हम लोग इधर ये केस में क्या किया था पारस?
Yes. So the patient was first optimized in ICU. One episode of hemodialysis was also done. Then patient was taken up for emergency laboratory. The per finding was there was a cross-prudent abdominal collection which was evacuated with a gangrenous rupture ideal conduit with a peristomal hernia with ideal loop as herniation content. We did a explorative laparoscopy with peritoneal lavage with a reduction of peristomal hernia content with resection of the iliac conduit with ureterosigmoidostomy with the pelvic.
Okay, so ureterosigmoidostomy was done. Fine. So we'll let you know what is the result. Okay. Huh?
Single ureter instead of ureterosigmoidostomy, that could have been better, right? Ureterocutaneous.
I think ureterocutaneous would have been better.
Ureterosigmoidostomy without assessing his anal
Capacity.
rectal holding capacity in emergency setup in a solitary functioning kidney. Again, one more anastomosis that may get simple ureterocutaneous anastomosis will be better. That's what I.
Correct. So this is I think the student should give this answer in the exam. So he has done quite well. Good. So we go to the third case. Short again. Fine. Paras.
Sir, one more thing I wanted to know in this case, who has a very bad history of compliance. Gaurang Shah, sir.
Bolo.
Sir, this patient having very bad history of compliance. As by ureterosigmoidostomy, he may have recurrent episode of chronic pyelonephritis and other things. So what this made you to choose this decision of ureterosigmoidostomy?
No, this case is not done by me.
Okay.
But we were there, so that is why we
okay.
Because we thought that it's a very interesting case for everyone to learn. You know, it comes once in a while. So that is why we wanted to discuss, and I think everyone has accepted and agreed that ureterocutaneous anastomosis will be the best thing. And otherwise, I think any other anastomosis with PCN should be done.
Okay, fine.
Correct. So even if you are doing again the ileal anastomosis or you are doing sigmoid anastomosis, I think PCN should have been done.
Right.
That way we are, the leakage and other things we are avoiding.
Right, sir.
Okay, fine. Go ahead, Paras. Who is answering now?
So Ojas.
Okay, Ojas.
Yes.
Yeah, Paras, go fast, huh? Okay, Ojas, this is a history. Difficulty in urination since 1 year, bilateral flank pain on and off since 3 months, and decreased urine output since 7 days. Just tell us how, different history you will extract, and we'll go ahead.
So first, I'd like to elaborate on the chief complaint. So regarding the difficulty in urination, whether the difficulty has progressed in the last 1 year, whether there is any urgency, there is any obturation, how is the whether other associated organ tracts associated the same. Regarding the flank pain, I would like to know the nature of the pain, severity, whether it relieves with medication, whether there is associated fever. Regarding the urine output, also I would like to know, like, was there uh, any other episode which precipitated the decrease in the urine output? I would like to know all this.
See, difficulty in urination, you should talk about blood. Okay,
Yes, sir.
storage as well as the
Storage in the voiding chamber. Yes, sir.
bilateral flank pain, 7 points should be asked, including hematuria.
Yes, sir.
So you have missed out on many points. And decreased
Yes, sir.
urine output, you must ask whether it is related to oliguria, anuria, or whether it is retention overflow because of the chronic retention. So that you have to differentiate in your history. Okay,
Yes,
Paras, go ahead. Paras, we can't hear you.
A patient was asymptomatic 1 year back when he developed difficulty in urination in form of increased frequency, nocturia, straining, weak stream, urgency, and a sense of incomplete voiding. The frequency score is 3, urgency 2, nocturia 3, poor stream is 3, intermittency 2, straining 2, and sense of incomplete void is 3. The quality of life is 2, patient is mostly satisfied. Patient also gives history of bilateral flank pain since 3 months. Pain is dull, aching, non-radiating, increased during urination, and relieved partially by medication. There is also history of decreased urine output since 7 days.
Go ahead, Paras.
Yes. Negative history, there is no history of fever, nausea, and vomiting. There is no history of any incontinence. There is no history of urethral instrumentation or surgery in past. There is no history of bleeding disorder, anticoagulant therapy, or blood transfusion. There is no history of leukorrhea or trauma or hematuria. There is no history of facial puffiness, pedal edema, breathlessness. No history of jaundice, headache, or fatigue.
Fine. Complete the history.
Patient in past history and comorbidities, patient is known case of hypertension and diabetes mellitus and is presently on medication. No history of ischemic heart disease, hypertension, pulmonary TB or surgery. Personal history, patient is mixed by diet, no allergy, sleep is normal and undisturbed, bowel habits are normal, no addiction to any form of tobacco or alcohol intake. Family history is non-family.
Fine. So just examination, show him and let him tell. This patient had recurrent hematuria after admission, and there was a usually the retention of urine. We had to give bladder wash. Ultimately, this before taking for a surgery, we had taken this photograph.
So I would like to ask for the surgical. Sir, at last, the surgical history, I can see a lower midline scars. I want to know about the surgical history as well. And
No, this is not a scar.
It is not a scar.
It is not a scar.
No.
Okay.
So just
sir,
what are the things you are seeing? Just tell us.
yes, sir. So the umbilicus is central. I can see a probably there's a distended bladder. The penis appears normal. Patient is probably circumcised. Bilateral groins appear normal. Scrotum appears normal. There is fullness in bilateral flanks. Yes, sir.
Okay, fine. Paras, go ahead.
General examination is grossly normal. On upper abdomen examination, abdomen umbilicus is central inverted, suprapubic fullness is seen. No visible peristalsis, pulsation, endogenous karma. No renal angle fullness was noted on the either side. On palpation, there is no tenderness, no rise of temperature. Urinary bladder lump is palpable. No other lump or hepatomegaly or splenomegaly. Genitalia circumcised penis. External urethral mucus is normal. Bilateral testes and cord are normal. On digital rectal examination, there is a grade 3 prostatic enlargement. It is non-tender, no fissure, fistula, or hemorrhoid. On percussion, resonant sound with normal liver span with dull note over the bladder lump. Auscultation, normal bowel sound. breast systemic examination.
So after listening his 3 complaints without touching the patient, that should be in your mind that this patient may have either a supravesical bilateral problem or infravesical urinary tract problem, because the patient had a bilateral loin pain and decreased output. Okay.
Yes,
Barabar.
So when it is possible, so either both the system has either blocked or
Or-
some medical problem associated which is causing the decreased urine output,
yes, sir.
or infravesical urinary obstruction.
Yes, sir.
On clinical examination, there are chances you may get distended bladder. That's what happened in this patient also.
Yes, sir.
Okay. So what is exactly inside? How will you go ahead then? This is the story.
Yes, sir. So first, I like to do general investigation, specific investigation. General investigations would include a complete blood count, serum creatinine, urine routine, and a urine culture. Specific investigations first would include, I would like to do first a sonography of the KUB region with again checking the post-work residue. Patient has come with retention. So in that, if the patient is having painful retention, first I like to catheterize the patient and relieve him of the distress of painful retention, and then do a bedside sonography and to assess the both side kidneys, to look for the ecotexture of the kidneys, the CM cortical matter differentiation, the fullness of the pelvic system, trace the ureter, look at the bladder wall thickness, prostate, and yes, sir. Then accordingly, I will proceed from there, sir.
Okay. Paras, just show him the investigation.
On urine routine microscopy, pH was 6.5, protein was 1+, sugar was present, RBC 22 to 25 per high power feed, WBC was 6 to 10 per high power feed, epithelial cell, testers and casts were absent, urine cultures showed no growth. The blood reports, hemoglobin was 10, uric acid was 6.18, creatinine is 6.48, PSA is 8.85.
Yeah, okay. So creatinine is 6.48 and serum
Potassium is
potassium is 6. Okay, now show the ultrasonography. That is what he has asked. Tell us the salient features. Oh, yes.
Yes, sir. So starting from the images, so this is the right one. Yes. So both sides kidneys, the cortical thickness appears normal. However, there is distension of the pelvic aeration system. There is hydronephrosis on both sides. The bladder is distended. There is the
First
bladder
finish
wall.
about the kidney. First finish
Yes,
about
sir.
the kidney.
Yeah. So
You are
there is
talking
no
about the cortex. Then you talked about hydronephrosis. Now, what else
Yes,
is
sir.
there inside?
There is no any stone. There is no any
No, no stone. No stone.
See carefully.
Can you see the acoustic shadow or you can't see the acoustic shadow?
Yes, sir. Yes, sir. Yes, sir. There is stone. Yes, sir. Yes, sir. There is a stone in the
Upper
pole. Upper pole. Yes, sir.
row,
Yes, sir.
third, second fill.
Yes, sir. Yes, sir. There's a stone in the upper pole. Yes, sir. There's a stone in the upper pole.
Lower pole.
See second film. Upper row, second film.
Yes, sir.
पारस सेकंड दिखा सेकंड नहीं उसके बाजू वाला
हाँ एक वो और उसके बाजू का भी चलेगा. Yes, yes.
Yes, sir.
So both the kidneys have got stones, correct?
Yes, sir. Yes, sir. Both the kidneys are got. Yes, sir.
And then see the bladder.
So bladder is distended.
Okay. After kidney, can you see the ureter?
Yeah, the ureter is distended. Ureter is dilated on in the left hand side film, sir. We can see that the ureter is dilated. I'd like to trace down the ureter. I can see till this point it is dilated, and there is probably a stone also seen there, sir.
Yeah,
Yes,
one thing.
Yes, sir.
Then what about the bladder?
The bladder is distended. The bladder wall thickness appears normal. There is no any diverticular or anything. There is no any growth or any calculus seen or any echogenicity seen inside the bladder.
Okay, fine. Paras, just say the result and we'll ask him.
In the report, there are two large calculi measuring 14 and 15 mm in the right lower pole of the kidney with moderate hydronephrosis. Three large calculi 15, 10, and 9 mm respectively in the lower pole of left kidney with moderate hydronephrosis. One large calculus of 13 mm in the right mid ureter and one large 15 mm in the distal part of the right ureter with moderate hydroureter. A large 12 mm stone is also noted in the distal left ureter. The prostate is 57.56 mm enlarged in size. The pre-void of the patient is 873 ml with post-void of 811 ml.
Okay, Ojas. Now you know all the.
बोलो भाई.
Yeah.
Yes, sir.
फटाफट बोलो अभी क्या करेगा.
Yes, sir. So the patient has bilateral obstructive uropathy because of stones on the distal ureter on both sides, and the patient also has probably also obstruction at the level of the infravesical level, and is in the prostate seems to be enlarged. So initially after catheterized, initially as the potassium is deranged, I like to correct the potassium. After putting the catheter, I like to see how much is the. Yes.
Tell us how will you
collect?
How will you correct
Yes,
it? How will you correct it? One of the OSCE was that only in exam.
So,
how will you correct it?
Correct. Yes, sir. So for potassium, yes, sir. So we'll start the patient on glucose insulin drip, GI drip. Then we can give aspirin nebulization. Then calcium gluconate and soda bicarb. This can be used for the correction of the potassium with monitoring of the ECG as well to look for any changes. And as this could be done. And after catheterization, we'll see how much is the urine output drain. Serial values of creatinine would be measured and electrolytes, because this patient has been probably in an obstructive state for a long time. So there is chances of patient going to post-obstructive diuresis. So serial electrolyte measurements every 12 hourly. And also to see in the initial setting for the if the creat would decrease with the catheter. After that, since the patient counts are normal, but there is bilateral obstructive cal in the lower ureter on both sides, the patient should be considered for the cystoscopy plus proceed bilateral DJ stentings.
You don't want to do
So
any other investigation?
Here patient had a bilateral large renal stone, bilateral hydronephrosis, bilateral lower large ureteric stone, and large prostate.
Yes, sir.
And that distended bladder may be due to prostate, may not be due to prostate.
Yes, sir.
So after placing the catheter, creatinine may come down, may not come down.
Yes,
there
sir.
are
Yes,
more
sir.
chances it may not come down because there is a double obstruction supravesical. Okay. So after
double obstruction
after starting the treatment in terms of correction of the potassium, so we have to bring it. Our first aim is to de-obstruct the patient.
Yes, sir.
So if the catheter went inside well, then it will take care of the infravesical obstruction.
Yes, sir.
Whatever the obstruction, it may be समझो स्ट्रक्चर है नहीं है, वो तो कैथेटर डालते समय पता चलेगा, या प्रोस्टेट है तो प्रोस्टेट का, या any other stone inside the prostatic urethra और कुछ है तो वो भी पता नहीं. तो वो कैथेटर डालना पहला काम है, correction of the dyselectrolytemia and correction of the dyselectrolytemia is another. So patient need admission, such type of patient need admission, first thing. Then correction of the potassium. Then the question comes, how you de-obstruct the system proximal to the bladder.
Will you like to do any investigation?
Now, yes, this is the question.
So a plain CT QB could be done, but
question here what sir has asked, because the aim behind asking this question is two things. One is the level of function in that 6 creatinine. ठीक है, इसका 6 creatinine है. So you have only one option in front of you. If you want to go for any investigation, is only NCCT.
Yes, sir. Non-contraceptive.
Other
Yes,
than
sir.
that, you can't do anything.
Yes, sir.
Because having a 6.48 creatinine in early phase.
Yes, sir.
And the both proximal two obstructions by stone may not causing a renal problem is very rare chance. So coming down of creatinine after placing the catheter is also a rare chance.
Yes.
Okay. So NCCT QB you can do. So on
Yes,
the then what is the current benefit of doing the NCCT? So why you want to do a NCCT? 1, 2, 3, 4, 5 जो भी तुमको रीजंस पता है वो बता दो. पंकज सर को भी सर एक बार अंदर ले लो. पंकज सर सो गए किधर के है कि नहीं?
Pankaj, your role is most important. Now you please take over in this case. By
Yes,
answer
sir.
the Ojas.
Yes, sir. So we want to look at the density of the stone. How hard, so that will we'll realize about that how hard the stone is based on the Hounsfield into the stone first. Second, we to know the we can also see the kidney, the parenchymal thickness, and the whether size of the kidney and the cortical thickness could be assessed. Then yes, sir, these two main things, and also about the stone architecture and the kidney architecture. The PCS architecture could be assessed better on a CT scan.
You don't want to see anything in bladder?
So bladder also any growth or any not the growth, sir, any stone is seen in the bladder, sir.
Okay, bye. Dekha the X-ray and CT scan. So we can go ahead.
What?
Gite sir, meanwhile you can tell him what are the advantages.
These are the X-ray.
Yes, sir. So this is the X-ray cave, well centralized, with
Just show
adequate
the
exposure.
क्या important features है बता दो.
Yes, sir.
Just tell me the stones.
Yes, sir. So on the right side, the lower pole, there is a stone of approximately 2.5 centimeter size on the right hand side, the lower pole. Left hand side, there are multiple stones in the lower pole, and in the left hand side at upper ureter, at L4, L5 level, there is another stone seen. Then
see the right side, lower ureter, middle and lower ureter. Just see properly. Iliac crest over
yes,
the iliac crest.
yes, sir. The mid ureter again. There is a mid ureter. There is again another stone seen. Yes, sir. Mid ureter level. Approximately 7-8 mm size. Another stone could be seen in the right mid ureter.
CT scan बता दे. Parak.
Yes, sir.
Now see the CT scan. Mainly you can see
So I can see the CT scan.
the right lower film, just lower line. You see the lower line and most of the things you can see.
Yes, sir. Right hand side, the cortical thickness appears normal. There is hydronephrosis in the lower pole. There is a stone seen. Then in the right upper and lower ureter, there are two stones seen. Actually, yeah, it's mainly lower ureter. So lower ureter, there are two stones seen on the right hand side. Left hand side, upper ureter, there is a stone seen, and there are multiple stones in the. Actually, there's a stone which is occupying the renal pelvis and part of the lower calyx.
Is there an obstructive stone in the kidney?
Kidney, no, sir, but in the
The
ureter,
ureteric stones are obstructive,
not completely. No, sir.
both the side. Both the
No,
side,
sir.
lower ureter is also dilated.
Yeah, but it doesn't appear completely obstructive.
So now what is your diagnosis? And what about the bladder?
Bladder wall thickness is increased.
Is there any suspicious thickening?
Yes, sir. At the dome, we can see dome
Yeah,
of the bladder. We can see a suspicious thickening. It's just one of the things.
yeah. So now
Yes,
what is
on
your
both sides. Yes.
conclusion? And the prostate also you can see very much enlarged.
Prostate is enlarged. Yes, sir.
So now what is your conclusion?
So the prostate is enlarged, so that might be one of the that was the reason for the retention and also for the race creat. For the bilateral ureteric dilatation could also because of the infravesical obstruction causing the dilatation. However, the stone, though they are not completely obstructive, the surrounding edema could be the reason for their proximal dilatation.
Don't you think
And
that these are just a fallen down stone from the kidney because of dilated pelvis and ureter?
so could be, so yes, sir.
So it is because of the dilated ureter the stones have fallen down, and not because the stone is fallen down, then it has caused a dilatation or obstructive uropathy. So now what is your conclusion? The obstructive
For you to
uropathy is
understand
because
that
of
there are ureteric stones, but
Yes, sir.
urine in the bladder and ureter was dilated below the stones. It was a very important finding in the city. Hello.
Yes, sir. Sir, sorry, I was not able to hear you properly, sir.
Yeah,
Yes,
I said in this case, the CT was very clearly showing the stones in mid-ureter and
Yes, sir.
the ureters were dilated below the stones. That was a very
Yes,
important
sir.
finding.
Okay, yes, sir.
So
Yes,
what
sir.
you
Yes,
should have thought of was either an outlet obstruction or a vesicle dysfunction. So
yes, sir.
basically bladder may be at fault also. Okay.
Yes,
So
sir.
if the
Yes,
if the prostate is not at fault, you have to also study the bladder.
bladder.
So therefore, it's not a straightforward case of just an obstructive uropathy. It could be obstruction to the stones, but there could also be a problem with the bladder and the prostate. So your
Yes,
job is to evaluate that and think about that. The reason this case was put for you was for that.
yes, sir.
Mahendra, you can leave. Maheshwari, now how to go about in such cases? How you will advise them to answer?
Basically, at this time, we are dealing with a case of severe bladder outlet obstruction with bilateral multiple stones. So I would place a catheter and see how the patient progresses.
Fine. Okay. So now the creatinine has little decreased. It has come to 4, and potassium is also now 4.2 or 4.3.
Causes, can it be a tuberculosis? Because the thickened bladder wall capacity looks like slightly less. The full length ureteritis, the ureteric wall also thickened, and there are stones.
Sir, actually, in this patient, sir, there is from starting from the points in history, there is no history of any pulmonary coughs. The history is of 2 to 3 years. On catheterization, the output bladder is 900 ml, so it was a large capacity bladder. And
Yeah.
Okay.
Yeah,
You
but
are not thinking
yeah,
about
so let's likely.
okay. So there may be some doubt about you may be suspicious about tuberculosis. You can send urine for AFB if you are got a doubt. Fine. So, okay, now what we did was that we tried to do a scopy. It was a very long urethra also, and very hard prostate, very difficult to, median lobe was very high. And just, yeah, show them what
So,
we saw.
sir, before going for prostate cystoscopy, so
Huh.
here there are two problems, as Pankaj sir also said. It is a
Hmm.
infravesical mechanical obstruction or neurogenic bladder.
Correct.
Correct. So if there is a neurogenic high pressure bladder, same picture is there usually. So it
Fine.
will compress the both ureteric opening and proximal hydronephrosis associated with the stones. So if you want to rule out the obstruction is infravesical or at the level of vesical level, so is there any role of any other investigation before going for cystoscopy?
This is the same hint that I tried to give you. That either it
Urodynamic
is a
study.
vesical dysfunction or it's a bladder.
So just what you will do?
So urodynamic study could be done, but
Very good. Yeah.
yes, sir.
Could
That
be
is
done.
what we were.
So if
You
you
should
don't
do
want
it.
to
That
do,
was what I was expecting. That is
Yes,
what
sir.
I told you
Yes, sir.
before. Gite sir has again given you the hint. So I said
Because-
either it is vesical or it is outlet.
Okay. Yes, sir. A
okay.
urodynamic
Fine.
study will be done and to assess, and then accordingly then proceed from based on the findings.
So when would you do this urodynamic test?
So you have placed a catheter and drained the 900 ml urine. So what is the prerequisite for going to the urodynamic study and when you will do it?
Initially, we'll assess the creat over a period of 3 to 4 days, whether the creat is falling down with the catheterization. And also with the USG to look if post-catheterization, if the hydronephrosis appears to be settled. But in this case, there is stones as well, so it won't settle, sir. Actually,
So what do you want to do for hydronephrosis?
so we will do stenting first, and then
There is dilated ureter seen just distal to the stone also.
yes, sir, that is also seen.
Then how stenting will help?
See, even if the stones may not be appearing totally obstructing, but definitely once the stones are there, it will slip down and it will go to the narrowest part of the ureter and will cause the obstruction. Right or wrong?
Yes, sir. Yes, sir. Yes, sir. So we
So
will
if
do
the-
stenting first, and
So if the after catheterization dramatically creatinine is not decreasing, what you will do?
so do a stenting or
So
a PCN
creatinine
insert.
is not decreasing. Decreasing means what is the interpretation? So either that both kidney has already got fired or there is a
Yes, sir.
supravesical obstruction.
Yes,
Okay. So you
yes,
have
sir.
not answered the question of Pankaj sir. When you will do urodynamic study after placing the catheter? Or you don't want to do urodynamic study?
So I will first, if the creat is not significantly decreased, I will first do a stenting or a PCN insertion. And if mainly a stenting, and then I will look for a urodynamic study. So first I would like to get the creat down.
You see, how reliable would a urodynamics be in a patient who has a stent?
Yes, yes, sir. I'm not very sure about this.
No. Think simply. Is that stent will cause bladder spasm and increasing pressure?
Yes, sir. It will.
Then is that finding will misinterpret
Yes,
your
sir. Yes.
result?
Yes, sir. Just curious finding. Yes, sir.
So in this particular case, if there is a bilateral hydronephrosis with dilated ureter and ureter seen distal to the stone also, so chances of having infravesical obstruction is more, or at the level of bladder is more compared to the supravesical obstruction. So after placing the catheter, creatinine is not coming down; it comes down by 2 only. 6 ka 4 ho gaya. Now question here is when you will do urodynamic study. That is the question again.
So for some time, let's forget the upper tract stones.
Okay.
Okay, this patient has come to you with chronic retention. You have put in a catheter, creatinine has come down from 6 to 4. So if with this situation, when will you do urodynamics?
So yes, sir. So if the creat has stable, that it has come from 6 to 4, and then this time, this case, we will do the around 4 to 6 days if the creat is not further decreasing.
Okay.
To assess the bladder function, because then we have to assess whether. Yes, sir.
Yeah, go ahead.
Yeah, so after catheter insertion, if the creat does not significantly decrease, in that case, after the stabilization of the patient in terms of the electrolytes and the other parameters, we can go ahead with the urodynamic study to assess the further treatment plan.
Okay. Are there any clinical parameters to assess for return of Detrusor function?
So pericatheter leak could be one.
Okay. What else?
Uh,
So basically, you see, there are three things you look at clinically. Patient may have a voiding sensation.
yes, sir.
Then patient would have bladder spasms and pericatheteric leak. So once
Yes,
you have these three things, then you suspect that Detrusor recovery is likely, and that is
Yes.
when you do a urodynamics to confirm that.
Okay, sir.
Otherwise, doing it at day 5, day 6 will not really benefit you, because more likely Detrusor would not have returned its function by then.
Yes, sir.
So if there are no clinical features, then minimum you should wait probably is 2 weeks.
Okay, sir.
Okay, so let's come back to this case now.
Okay, so now I will tell you what we did. Just show them what we did, Paras, and then we'll just go ahead.
Yes, sir.
Yeah.
Patient was catheterized, 900 ml urine was drained with slow decompression. Patient was managed with fluids, antibiotic and electrolyte correction was done. After 24 hours, repeat investigation, serum creatinine came down to 4.28 and potassium of 4.5. The patient was later taken up for surgery after 3 days. Bilateral URS with TFL of ureter stone with bilateral dejustenting was done. After 36 hours post-surgery, patient was discharged with Foley catheter in situ with serum creatinine of 2.8 and other normal parameters.
And just show the finding by.
This is the C-arm view showing tortuous ureter. This is on the right side, this is on the left side.
Cystoscopy finding.
Yeah, this is a cystoscopy showing urethritis with bilateral lobe, with lateral lobe enlargement of prostate. This is the bladder mucosa which we found on cystoscopy. This is mainly the anterior, right anterolateral wall in the third, on the left side lower image. A TURBT was done for the same. Whole of the bladder mucosa was edematous, reddened, and
Okay. So Ojas,
Yes, sir.
prostate was median lobe was so high and the bladder capacity so much, it was so difficult to go either to find out the ureter also and also to do any procedure. So now
Yes, sir.
this patient, we have already stented him, ureteric stones have been dealt with. Now he has got bilateral renal stone, he has got enlarged prostate. Urodynamic study we have not yet done, and we have done the biopsy. So I am giving you the 4th scenario. Okay.
Yes.
Scenario
Yes.
number 1, when the biopsy is negative, showing chronic cystitis. Okay. Urodynamic study says that the adequate detrusor contraction, bladder outlet obstruction, and now he has got bilateral stone. So what you will do?
In this case, first a TURP to get rid of the bladder, the intravesical obstruction. TURP, and then deal with the stones in the other setting, or in the same setting as well. But TURP has to be done.
How you have confirmed that obstruction is there by the prostate?
UDS was suggested that there is.
No,
I will have to
UDS has not done.
No. I'm giving him scenario where UDS is done and it is
Okay.
showing. So that was the first scenario. So he said that he will dealt with prostate first and then the stone. Now, if urodynamic study is showing that Detrusor is not contracting and even the biopsy says that it is non-malignant, how will you go about?
But I will let you know the Detrusor pressures first. So in that case, also, if like Detrusor pressure, if they are very low, in that case also, if relieving the obstruction would with the patient being explained that relieving the obstruction by doing a TRP along with added probably the patient might require CIC later on if the contractions are not adequate. But a TURP would also help in the setting because it will help to relieve the mechanical obstruction at that part. And with the addition of Bethanacol or this along with maybe not possible, then CIC.
Okay. So in this case, you will like to do TURP and then again tackle both the stones. Maheshwari ji, you want to comment anything on this?
No, sir. I think proceed.
Okay. The third scenario is that bladder contractions are there. That is a contraction, but this is turns out to be non-invasive TCC.
Non-invasive TCC. Okay. In that case, first a TURBT. Okay, so TURBT is already done. Yes, sir. Yeah. Okay.
No, total TURBT we could not do.
Yeah. So we will do a re-TURBT to assess the muscle to get adequate
But we are not
sample.
able to. We are not able to do it because of the prostate.
Then do a TURP along with re-TURBT in the same setting.
Okay. And if it is still showing non-invasive, non-muscle invasive, then you'll do bilateral PCNS.
Yes, sir.
And then when you'll do BCG?
BCG, sir. Yeah, TURP you are done. So after 6 weeks, you can call for the BCG, so the induction regimen.
With stent in situ?
Yeah. So at 6 weeks we'll remove the at 6 weeks we'll remove the stent and then but no stent we are not tackled the stone. So we have to deal with the stone first in that case. Yes, sir. Stone first in that case, then stent removal, then during the stent removal we assess the bladder again and then go for BCG.
Okay. I think is this okay? Maheshwari ji?
Yes, sir. I think too many variables. So
Variables, I know. So
yes.
and then the
Only-
last thing.
Only thing what I want to tell is in a patient with whose NCCT QAB shows very dilated ureter or dilated torsus ureter and scopy, if it is suggestive of mass what you have shown on the scopy, I will prefer better not to place the DG. I will prefer to go for PCN considering the large stone in the kidney. So that will be the better idea than placing the resistant in such situation. That's what my personal feeling, may be wrong.
No, you're right. PCN is always, yes, PCN. I think even the answer of doing decompression by putting a catheter and bilateral PCN, I think is one of the good options. That's also fine.
Pankaj
It is
sir,
a good
after
option.
chart
Because you can
creatinine-
always say that potassium was raised. You know, the anesthesia may be difficult in such cases. instead of waiting for like if the creatinine is not decreasing and we have to treat him, then PCN is a better answer.
Because after placing the periureter catheter, creatinine is still 4. Dilated tortuous ureter.
Then better to put PCN. Yes.
Bilateral large ureteric stones.
And bilateral renal stones, which would, as it is, need a percutaneous tract.
Correct.
So I say situation may better to go for PCN. That's what my feeling is.
I agree with you, because definitely this tract will help us for the future PCNL also.
Yeah.
Yes.
And we can that time we can tackle even ureteric stone.
Yes.
Once we know the report of biopsy. Fine. So the final question is, if it is a TCC muscle invasive and this is a situation, now what you'll do?
So if it is muscle invasive, first I like to tackle the stones because we as in because the patient he will require a radical cystectomy. So before that, the kidney function, the GFR has to be assessed, has to be normalized. So we'll tackle the stones first and then counsel the patient for a more radical procedure.
Okay. Now you have answered quite nicely. Now only my one question is, Paras, what is the PSA?
8.8.
So you never asked for that and you never explained about this.
Yes, sir. So
So 8.8 PSA in gray zone.
So free. I would like to see the free PSA, total PSA ratio.
First of all, have you asked us when we have done the PSA?
Yes.
Patient was in retention. All these so much
Yes, sir.
things
Yes, sir.
of-
Yes, sir. I would like to
You could
repeat
have
the
just
PSA.
said, I'll repeat the PSA. no?
Repeat the PSA. Yes, sir. Yes, sir. Yes, sir. I'll repeat the PSA and then decide about it. Yes, sir. Sorry, sir.
So repeat the PSA. If still is in gray zone, then give the antibiotic. If still is in gray zone, go for the percentile free and total PSA. And उसमें भी अगर पॉजिटिव आ रहा है तो फिर एमपीएमआर आने तो पेट पीएसए में पेट स्कैन
Yes, sir. Yes, sir.
उसमें पॉजिटिव आया तो बायोप्सी.
Understood?
Yes, sir.
So these are important things you must not miss.
Yes, sir.
In exam, presence of mind is most important.
Yes.
Okay, that is why we have taken this case where multiple things are there. Like
Yes,
whether PCN versus DJ scenting, biopsy, what it comes, all these things. The idea is that when you start your practice also and you'll come across such cases, you will not get confused. You will be very clear in your mind that what you want to do.
Yes, sir.
Okay?
Yes, sir.
Okay, fine. I think any other questions, Gite sir?
No, someone has asked in chat, can PSA will be hit after catheterization or in retention? So yes, it can be hit before when patient is in retention. So I have seen benign PSA due to retention up to near about 10, 20, 30 years, which is persistently biopsy is negative in spite of doing saturation biopsy also.
Correct.
So maybe, sir, the addition to that answer can be that yes, catheterization or rectal examination usually doesn't change the PSA much. It remains within the confines of the gland. Only a breach in the basement membrane, like biopsy, really changes the PSA. But here, this patient could also be having associated infection, prostatitis. Therefore,
not only that, it is a large prostate, and when we
large prostate also, sir.
yeah, when we
volume
do the
adjusted
catheterization,
prostate,
it might have caused some trauma because he developed,
Correct.
he had a retention because of the clot also. So the bleeding was also there. We don't know from where.
Correct.
Fine, sir. So then I think we should stop here. And I'm trying that Friday, we will keep it 20 OSCE once I get it. Okay? I will let you know.
Yes, sir.
Okay.
Good night, sir. Good night,
Thank you
Gita
so much, sir.
Good night,
Thank you,
myself,
sir. Thank you, Gaurang, sir. Thank you, Gita, sir. Thank you, sir. Thank you, Maheshwari, sir.
Good night to all of you.
Good night, sir. Thank you.